So with that, we're going to bring up Roger. Roger's going to talk to us about clinical research update, about what's new in the research world. Roger's South Dakotan, I think South Dakota State for nursing, and then he did his NP training and things at the University of Washington, and came back. He worked for the flight team for a period of time, and when John Drury, one of our cardiologists, came to Rapid City from St. Louis University, he saw Roger and kind of tabbed him for starting a research group. And that research group, like I said, was Roger, and expanded to now 20 employees. And it's amazing, you go to national meetings and you meet with all these people and people in the research world, formerly Black Hills Cardiovascular Research Group, now the Monument Research Group. I mean, people literally around the world know who we are. So Roger's done a great job making sure that that happens, and so he's going to give us an update on what we got, what our new trials are, and how you can get involved in that if you'd like to.
Which is the clicker?
Yep, that one. Yep.
Can you hear me? Okay. Thank you for inviting me to this conference. Given it's the 25th anniversary, I can't help but wax a little bit nostalgic. When I remember back 25 years ago, 26 years ago or so, we had just started clinical research, and I was anxious to get the word out, tell everyone about the fun studies we were doing. And so if I remember the conversation right, I suggested we should start our cardiovascular symposiums again, and I think it was Dr. Purdy who said, yeah, great idea, go ahead. So for the next 10 years, we put this symposium on, so there's no one more thankful than me to the people that continue to put it on. It's a lot of work, but we enjoy it, and thank you very much for continuing it. I stumbled on to my role accidentally. I never thought I'd be a clinical scientist, a clinical researcher. But I went to, my graduate school is at the University of Washington, and research was going on all around me. And it was very stimulating. There was all kinds of questions I hadn't even envisioned that people were exploring. I worked night weekends on the cardiothoracic transplant floor, and all the other people that worked night weekends were also graduate students. So it was a great place to learn, great place to be stimulated. And when I came back here, I quickly recognized this is the perfect place to do clinical research. We kind of live on a geographic island, a lot of people around us, and they come to one central place for their health care, which is important for clinical research because clinical research is collecting information. So I was thrilled when I had the opportunity to do clinical research here, and it's been a very stimulating career. And I owe a special thanks to Dr. Durr and Dr. Purdy, because they took a chance. They hired me as their nurse practitioner. I think I was the first nurse practitioner here in this system. And I always think back to that first day I showed up. I didn't have a job description. No one was sure what I should probably do, which is perfect for me. I love not having a job description. But just carving out a role and looking for areas where I could be helpful. And I would encourage all of you early in your career, look around you, look for areas where your heart is, and follow that. There's a lot of things that we each can do, and if you see a niche where you can fit in, go ahead and reach for it and pursue it. So, enough with wellness, right? Let's talk about some of the new, exciting, expensive stuff coming at us. I'd like to, first of all, my objectives are to introduce everyone to clinical research. Not everyone knows we do clinical research, because we laughed, like Dr. Pretty said, around the country, everyone knows Monument Health does clinical research, but a lot of people here don't. They don't know until we call them up and say, hey, looks like you might qualify for a clinical trial. Or one of their practitioners says, hey, I'd like you to talk to clinical research and see if they have something that'd be helpful. I'd like to introduce the clinical research team. I'd like to showcase our current enrolling cardiovascular trials. These trials I'll be talking about are just our cardiovascular ones. We do other kinds of trials too. Our role is to provide an infrastructure for our investigators who have an interest, a device, a therapy they'd like to work with, and my team provides the infrastructure so that they can do that. I'd like to, most of all, highlight some new paradigms that you're going to be seeing over the next few years in cardiovascular research. Factor XI inhibitors that Drew already introduced, lipoprotein A, inflammation in general in cardiovascular disease. And then I think I've seen the flyer around. I'm not sure where you got it, but we sent a flyer around with an app that we just are now participating in that allows you to see what clinical trials we're enrolling in. You can see the inclusion, exclusion criteria, and if you scroll down to the bottom of any of these trials that you're looking at, there's a one-button contact to get a hold of us. So I'll end that with showing you that again. So first of all, my staff. Most of us think about working on a team, wish we worked on a team. I do work on a team. Got a great staff. They all think they do important work, and we do important work. We get 15, up to 15, 20 new trials every year with exciting, stimulating questions. So it's great work. We're all engaged, and I'm lucky to have a great team. We, like everyone here, has productivity goals, financial expectations, and we do too. When we see patients in clinical trials for visits, those are usually time points that we get paid, like you get paid when you see a patient for a follow-up visit or an H&P. And when an average phase 3 trial, we see the patient over a 4-year period of time, maybe 10 to 12 visits during that period of time. So once a patient's enrolled, those are scheduled out into the future. This is my latest, greatest attempt to organize our clinical trials, and it's difficult. We carry up to 40 active trials at any given time. About half of those are enrolling trials, and I can't keep track of it, let alone expect you all to keep track of it. Hence the app I just told you about that where you can look the trials up. So I have a hard time kind of seeing this, so I might move over here. What you're looking at here is our current enrolling cardiovascular trials. To the left, with the blue background, are our lipid modulating trials. So you can see there's a lot happening within that group. Now we've got atrial fib, we've got acute coronary syndrome up at the right, we've got a couple heart failure trials, and then we have some overlapping areas like inflammatory modulation. We've got aortic valve disease with 2 totally different kinds of trials looking into that. So I'm going to keep referring back to this as we move forward. And one of the things I need to, we're kind of pressed for time, and I always try to cover too much in my talk. So I don't need to cover all my material, and you don't need to memorize any of this. This is all new stuff that you're going to be getting reintroduced to over the next years. So I'll take my time, and we'll cover as much as we can. So first of all, let's talk about atrial fibrillation trials. And off to the right, there's an acute coronary syndrome trial. So really what we're talking about is new anticoagulation. Drew already introduced the factor XIa inhibitors, and I'll try to go through this is one of the areas I'd like to spend a little time on, and I'd really like to encourage you to do some reading yourselves on factor XIa inhibitors. So we'll dive in. So why do we need a new anticoagulant? We've been through this a million times. Our DOACs are pretty good, really. They're first line, they're way better than warfarin. But bleeding's still an issue. All of us as practitioners just hate it when we're the ones that cause a bleed. There was a study done some time ago that looked at our prescribing habits after we have a patient in patients with atrial fib. And after one of our patients had a bleed, it affected our prescription patterns for the next months. We wrote less prescriptions for anticoagulants, knowing, we all know that those people need to be on anticoagulants and they prevent strokes. And conversely, when we had a patient have a stroke that probably should have been an anticoagulant, that did not affect our prescribing pattern for anticoagulants. It wasn't an avoidance or a big push after that to get more people on it. So we hate it when people bleed. Because of that, I think, and because of cost and all the other myriad of things that get in the way of our medical therapy, about a fourth of the people are underdiagnosed because we're kind of scared of that bleeding. And then 2/3 who are eligible aren't, less than 2/3 of those eligible aren't receiving anticoagulations that really should be. I was thinking back of all the anticoagulation trials. It seems like maybe 5 years ago or so, but I pulled up the anticoagulation trials that we had been involved with previously, and you can see us back in 2001 where we started working with enoxaparin and moving into all the other anticoagulants that we utilize today. So it was about a 10-year period. There was a lot of action, and there hasn't been since. It's been really quiet until these factor XI inhibitors. So why are these interesting? Here's my Confucius wise statement of the day. There are only two pathways to coagulate, but many ways to bleed. I'm not sure what that means, but it sounds pretty cool. So, coagulation cascade. We have two pathways to coagulate. One pathway protects us when we get cut, when we get a hole poked in us, and the other pathway really amplifies the process when the intrinsic pathway gets involved. So, like we've been looking for years, we're looking for the anticoagulant that stops, forms a clot when we need it, but doesn't form a clot in a pathological situation. So we want that right side, the extrinsic pathway, that protective hemostasis side, to remain intact, remain active. It's that left side, the intrinsic pathway, that has more. That's when that side gets involved, there's more of the pathologic things that we think about, the clots from AFib, acute coronary syndrome, CVA, those sorts of things. The other problem is when you get both sides involved, there's an amplification feedback system with thrombin. Once thrombin is in the equation, that just ramps it up, makes it much worse. So we want to avoid that. So when we're not on an anticoagulant, when no anticoagulants on board, a clot's formed when we have tissue injury. And sometime a pathological clot forms. When we take most of the anticoagulants that we have available, all of them actually, they block part of the pathway that we want to keep intact because that's where they work, and I'll show you that later. So they do protect us from the clots we're trying to avoid, but there's a cost of bleeding, always has been. What we hope is factor XI inhibitors uncouple that hemostasis from the thrombosis. With this therapy, it keeps that left side of the system from getting involved. It blocks just above the common pathway. So we think we can keep our protective pathway totally intact and still keep that amplification from happening. So this shows both sides of the clotting cascade again, and you can see in red where our current anti-thrombotics and anticoagulants work. They're down in that common pathway and they interfere with our protective. So I think I've hammered that enough. When we're looking at a new compound, a new therapy, a whole new area, it's helpful. It makes me feel better when I understand there's normal physiologic things that also support the concept. We're not groping in the dark. So with factor 11A inhibition, we know that in mice models, when that's knocked out, we see the right things happening. They're protected from thrombosis, but they don't have significant bleeding tendencies. And those of us who have factor 11 deficiencies are also protected from both arterial and thrombotic strokes, just naturally. And you can see that here. People have lower levels of factor 11, less arterial bleeding, and a lot less thrombotic events. There's a lot of work being done in this area, as you might imagine. There are 2 medications in phase 3, and we're working with both of those medications. What we've seen in studies so far in early phase trials that for thrombus prevention, it's at least as effective as enoxaparin, with significantly less bleeding. In atrial fib, we see less bleeding than enoxaparin. After stroke, there's less bleeding. And after MI, there's less bleeding compared to placebo. So as you can, there's a theme developing there, less bleeding, and that's what we're hoping for this medication. In fact, what we've seen so far is 50% less bleeding. And that's from the nuisance, cutting yourself, shaving bleeding, to bleeding in your head, catastrophic bleeding. We're working with Bayer on the Ocean AF trial. That's an atrial fib trial. It's about a 4-year trial. This medication is being compared to enoxaparin, to apixaban, I mean, and both medications are provided throughout the 3 to 4 year trial. So it's a nice thing for our patients, getting the medication free. And for our older patients, for our patients that were a little nervous whenever we're writing a prescription for an anticoagulant, is something you might think of because of less bleeding. Also, those people who should be on one of our newer medications that can't afford it and are still on Coumadin, like my dad, who I can't talk into changing. We're also working with Janssen on their new factor 11A inhibitor. They have an AF trial very similar. And in general, I can say when we're looking at both of these atrial fib trials, but because whenever we're using a new anticoagulant, everyone that works with the patient kind of freaks out. So if one of your patients is in our trials, you can just treat them like they're on apixaban. The medications, the new factor 11A inhibitors work very similarly. They're onset, offset, so you can treat them just like they're on it. You'll remember when I talked about the coagulation pathway, there's that thrombus activation portion. And we've known for a long time that after people present with a myocardial infarction, they have high levels of thrombin, and that persists for a long time. We're not even sure how long that persists, but at least a year or so, and that sets us up for another heart attack, another clotting situation. And our platelet therapy, our antiplatelet therapy doesn't really protect from activation from that standpoint. So we've known for a long time that if we could get an anticoagulant on board in that early, probably year-long setting after a myocardial infarction, warfarin prevented a lot of heart attacks and strokes. But the bleeding cost is too much on top of the antiplatelet therapy, like you all know. So this medication is another opportunity to look at that setting. because in this setting, we're using the new factor 11A inhibitors with 50% less bleeding, and we're able to use them at quarter dose, low dose, and still get thrombotic protective. So we're also participating in the Librexia ACS trial. So patients who just came in with a myocardial infarction, have multi-vessel disease, are pretty sick people, pretty high-risk people, I should say. And the FDA wants us to get this medication on board within 7 days from the onset of symptoms, because we think the protection is going to be early on when all that thrombin is running around in the system. Next, I'm going to talk about lipoprotein A. Lipoprotein A is lipoprotein we've known about for a long time. We know it's a bad actor. We know it causes cardiovascular disease, aortic valve calcification and disease. But we have not had a therapy that really impacts it. Our traditional lipid-lowering therapies don't impact it significantly, but now we do. We've got a couple of therapies, and again, we're working with both of the new therapies, and they markedly impact lipoprotein A. So lipoprotein A, independent risk factor for atherosclerotic disease, including coronary heart disease, ischemic stroke, peripheral arterial disease, calcific aortic valve disease, and it's 70 to 90% determined. So all of us have lipoprotein A. I'm proud to say mine is less than 7. I checked it as soon as we started doing this sort of work because I have a family history. But it's about 1 in 6 people who have a really high LP little a. And really high, the highest we know of is 2,500, but most of us land 0 to 50. Anything over 75 is considered a risk factor, an independent risk factor. So we're really interested in who has it because it's genetically determined. If you have one of your parent has it, you have a 50% chance of inheriting the genetic trait to have a high LP little a. LP little a is an LDL that's carrying a samurai sword, simply put. I'm being facetious, of course, but it looks like a samurai sword. And it's an LDL particle, but it's that attachment that makes it especially lethal. Again, genetically determined, influenced by that additive piece there, and we're not really sure what its initial purpose may be, something having to do with fetal clotting or protection, but it is noxious. It causes excess oxidation, it's pro-inflammatory and pro-thrombotic at the same time, which is a terrible combination. And again, we have 2 new therapies, olpasiran and pelacarsen, that we're working with. When we look at down to the left bottom corner, you can see kind of the normal layout of people's LP little a. And our current trial that we're enrolling in, you have to have an LP little a over 200 to be in the trial. So that's pretty high. And we've found that in the people we're looking at, we're finding about 1 in 6 people has a number in that range or higher. When we think about lipid lowering, as we've heard, if you can drop LDL by maybe 40 points, you get 22% reduction. But with LPA, you need a much larger drop to get that same sort of drop, same sort of risk reduction. So you need about 100 millimoles per liter drop. And that's what we measure our LP little a here at our lab. The other measurement is mass, and those numbers are very different, so you have to kind of pay attention to what you're looking at. So you need about 100 millimeter drop, but our new medications are powerful. The Horizon trial that we finished enrolling in, and we're still following them, and we'll follow them for another year or so. This will be the first trial that comes out. Their medication dropped the LP little a by about 80 to 85%, so very, very effective medications with very few side effects. The other medication that we're working with that we expect to continue to enroll through December, their medication they picked a dose that's down there in the bottom, and they have a 90+% reduction. So if we can find people in the 200+ range and reduce it by 80 to 90%, we're hoping that we can see a big difference in outcomes. The other reason we're very interested in these, when we're looking for people that have high LP(a), we're looking for the average person would be like someone who comes in with a heart attack at age 53 and has multi-vessel disease, or that person that had their first heart attack in their 50s and has been in 2 more times and got more stents even though they're on excellent therapy. Those are the sort of people we suspect maybe they have a high LP(a) hiding in the background. Again, this is kind of looking at the normal distribution. We don't have any approved therapies. Well, I take that back. You can, what's it called when you pull it off? Paresis, yes. That's the only approved therapy. Other than that, we don't have any therapies right now. But CEPT inhibitors and PCSK9 inhibitors decrease PCSK9, depending on the agent, by 20 to 30%. So if you have someone who's on high-intensity statin, early MI, and you know they have an elevated LP(a), if their LDL is still elevated on high-intensity statins and you have to reach for another medication, pick a PCSK9 inhibitor or a CEPT inhibitor. And think of referring them to research. Next, LDL modulation. We've been working with LDL modulation forever. There's all kinds of stuff going on. If you have a patient, just like I described, they've had a heart attack, their LDL remains above 70, although they're on a high-intensity statin, they're bulking at another $200-300 a month for another medication, think about sending them to us. We've got a lot of stuff going on. We've got, just talking about this whole layout of our trials, those yellow trials are ones that have, the ones that are background of yellow, those are just starting or haven't started yet. So we've got oral PCSK9 inhibitor trials starting next week. I think we have our first patient scheduled. So that's kind of exciting. Think about your patients as you see them, anyone you think that might benefit from that. We finished enrolling a trial with CEPT inhibitor, the year-long dose-finding trial, but we've got the outcomes trial still going on. And we're just starting a trial called PREVENT, which is with inclisiran for preventative care. We've not really worked in the preventative arena before, so that's interesting. We worked with inclisiran for at least 12 years now. We started working with it at its very inception. So it's interesting to think about from the preventative standpoint. For instance, if you have a patient that had a stress test, did okay, but they're high risk, think about them for a preventative. That's a 6-year trial with inclisiran, so really nice for our patients who qualify. I'll move on for the sake of time here. Hypertriglyceridemia. We've got 2 trials with hypertriglyceridemia, same medication. One is for people who have triglycerides over 500, and one is for people that have triglycerides between more than 200 and 500. The CORE 2 trial is nice because it's a year-long trial, but afterwards patients get open label therapy for 3 years. So free therapy for 3 years after the trial, and everyone gets the therapy. Next, we've got a couple trials for acute coronary syndrome. One I've talked about already, anticoagulant in the setting of acute coronary syndrome. And the other one's really interesting. It's an antiplatelet medication, a very powerful antiplatelet medication that comes in the form like an EpiPen. So these are patients that have had an MI, have multi-vessel disease, high-risk patients again, who maybe live 20 miles past Belle Fourche, and we send them home with 2 of these EpiPens, and if they think they're having another heart attack, they use their nitro as they're instructed, call 911, and then use their antiplatelet therapy. Within 15 minutes, more than 90% of their platelets are inhibited, and that effect goes away completely after 24 hours, just in case they need bypass grafting surgery. Perfect medication for us that live in rural areas. Heart failure, we've got 2 very different trials. The LA trial we've just started, and it's an interarterial shunt to take that pressure off that pressure in the atria and hopefully relieve symptoms of those people with preserved heart failure, preserved ejection fraction, and really significant heart failure. The other is anti-inflammatory therapy, and you're going to hear a lot more about anti-inflammatory therapy in the cardiorenal area in the future. We're just kind of getting started in that. The other trial that we're looking at in that anti-inflammatory modulation arena is this trial here that doesn't have a name I can remember yet, but I think it was Monday, we enrolled the very first patient in this international trial, so that was kind of fun. And I'll talk a little bit about inflammation. We were involved in some of the, I'm kind of jumping ahead here, we were involved in the CANTOS trial years ago. I was thinking it was like 5 years ago, so one of my staff looked it up and it was like 11 years ago. But we were the highest enrolling site in this trial, and it was important because we know inflammation is a big part of acute coronary syndrome, but we've never had a therapy to impact, and I'm really out of time already? All right. So, all right. So CANTOS therapy showed us we were on the right path. We found that if we interrupt IL-6, actually made a difference, a significant difference in mortality, morbidity. So now with some other recent studies, we know they're on the right track, and there's a lot of work that needs to be done in this area. Like I said, we just enrolled the first patient in the ACS, in the acute coronary syndrome, and we're looking forward to working with our heart failure population with the other trial. So I will quickly wrap that up because I want to answer any questions that you might have. Questions?
We'll see what we got.
I got a question back here.
All right. I feel like a failure if there's no questions. Come on.
Don't worry, we'll get you some.
Hi, Roger. I don't have a question specifically on a clinical trial, but I was wondering, with your department, budget's been a big deal, and you guys have grown so well. I was wondering where you get funding for your research department, and that's the first question. We're funding federal, Monument Health, pharmaceutical companies, and then after that, you say you do 15 to 20 trials a year. How do you pick which trials to do?
Good questions. Most of our trials now come to us. Like I said, most people that do cardiovascular research across the country know we do research, and they know our investigators. Dr. Purdy's done over 50 trials. So most of our trials come to us, and then we in turn go to our physicians and say, what do you think? Do you think this would augment what we do? Would this work in our practice? Does this make sense? Is this a therapy, a device? Sometimes our physicians come to us. We're doing a new TAVR trial for people that have moderate disease, and Dr. Tuma was interested in doing that, so we approached them to get the trial. We get paid, when we take on a trial, we contract to do the work for these companies. And we traditionally get, like I said, when we do a phase 3 trial, we see the average patient about 10 times during a 2 to 4 year period of time. And for instance, we get $1,200 when we screen and enroll them. We get $400 for each follow-up visit, and they pay us $1.50 for phone calls in between. And that's how we get paid. So some of these are device companies, some are the federal government, some are pharmaceutical companies. It just depends on, we call them sponsors of the trial. We like to work with academic groups like the TIMI group, Duke Clinical Research, who we did some of our first studies with, because they approach trials from an academic standpoint and are trying to learn as much as they can from the trial, not just to get a medic approved to sell, which of course is the main goal, but also learn as much as we can. So there's funner, more interesting trials to work on. And was there a second component to your question? I can't remember. Okay.
Okay, Roger, I got a question over here.
Are all your trials part of multi-center cooperative trials?
Yes, a good share.
Do you have anything that originates from here?
Yes, another great question. We have done a couple investigator-initiated trials, and what Dr. Hott is asking is, do we do multi-center trials for where, for instance, it's being run by Duke Clinical Research, and there's 80 sites across the country and 200 sites around the world. That's a multi-centered trial. I would say 2/3 of our trials are probably large multi-center trials, because those are the kinds of questions we're interested in. Having said that, we've done several phase 1 trials, and we love doing phase 2 trials because very interesting questions. You're working directly with the people doing the studies. So we do all the way from phase 1 to phase 3 mostly, and mostly multi-centered. We've just done a couple of investigator-initiated trials, and that would be, for instance, if Dr. Schabar came up with a peripheral question he was interested in doing, we would look to try to get funding to support that question and help him do the study and then ultimately publish it. We'd love to do that, but most of our physicians come here to take care of patients and do clinical work. They don't come here with the intention to do research. We hope it's a happy surprise when they get here that, oh, I can do research and I do have an infrastructure to support it. Yes.
Hi, Roger. Nan.
Yes.
Could you speak to when and how often physicians should be checking Lp(a) levels? And John asks that your answer be brief.
All right.
With all due respect.
So, in Europe, it's really approved. If you have coronary artery disease, you probably should check it once. You only need to check it once. If it's high, it's high. It's been high your whole life. If it's low, it's been low your whole life. What we hope, though, over time, when we do have a therapy, that we can identify those high-risk people who have a high Lp(a) when they're 35, get them started on a medication like this to push out that heart attack until later or avoid it altogether. So I'm always encouraged, when I see a young person, 50-some-year-old, come in and I read they have a history, a family history, I would like to see you all thinking about checking an Lp(a), but because it's research, I hesitate, and I shouldn't really push that because we don't have therapies for it yet. But it's something you should be starting to think about, because we will soon have therapies, and it'd be nice to know who our patients are that could benefit from that. And that's the benefit of doing clinical research in our committee. In our community, by the time a medication's approved, our physicians have been working with that medication for 10, 12 years, and we immediately put it into practice if it's appropriate. So thank you for your time.
I think we'll